University College of Medicine. Her areas of clinic and research expertise are in cutaneous disorders that disproportionately affect people with pigmented skin, including scarring alopecia, hidradenitis suppurativa, cutaneous T-cell lymphoma, cutaneous sarcoidosis, as well as health disparities in dermatology. And her medical degree is from Columbia University College of Physicians and Surgeons, and she completed her dermatology training at Yale University. She serves as the medical lead for Howard University's COVID-19 Community Testing Initiative, and she also received the American Academy of Dermatology Presidential Citation and a Volunteerism Award. She serves on many editorial boards, is cited in multiple publications, and we are just so happy to have Dr. Okoye with us today, and we'll just let her take it away. Welcome.
Thank you, Dr. Allen, and thank you for inviting me. It really is a pleasure to follow Dr. Barbosa. I've followed Dr. Barbosa before. She did her residency training at Yale a few years before I did, so I always think she paved the way for me. And she's been doing research on hair long before it was cool. And so a lot of the information that we have about the differences in the structure and function of African type hair is from some of the work that she did when she was at L'Oreal. So we had a giant lecturing to us first this morning. So always a pleasure to follow Dr. Barbosa. So we're going to be talking today about pseudofolliculitis barbae and acne keloidalis duci, PFB and AKN for short, because they're quite a mouthful. These are my disclosures. None of them are relevant to today's presentation, but I will be discussing many off-label uses of medications because nothing's on label for any of these conditions. Nothing is FDA approved for PFB or AKN. And so we will review the pathophysiology of both of these diseases as much as we know anyway. We'll talk a lot about the clinical features, the risk factors for developing them, and then we'll talk a lot about treatment and prevention strategies. So let's start with AKN. So AKN is basically a chronic scarring folliculitis of the occipital scalp and posterior neck. It's much more common in young Black men, but it really can occur in anyone. It can occur in women, it can occur in people of other races. And in AKN, patients develop these very dynamic papules and sometimes pustules on the back of the scalp, and it's called keloidalis duci, but these aren't actually true keloids. If you biopsy the lesions of AKN, you'll actually find folliculitis, not keloidal collagen. But over time, if a patient is keloid prone, they can develop keloids in this area. The papules can coalesce into thicker, broad plaques that are almost plate-like. And lots of secondary sequelae can occur, scarring alopecia, infections, really some disfigurement in general. And I think this disease has quite an effect on patients' quality of life, and I think that's under-recognized. So in terms of risk factors for AKN, I think this is really important. It may be a marker for metabolic syndrome. And for me, that's really important because if the majority of patients coming to see us are young Black men, there's a chance that you are the only provider they've seen that year. So we take it upon ourselves to do, of course, blood pressure checks, which we do for every patient, but we also would check a hemoglobin A1C and a lipid panel in our patients, and then connect them to a primary care provider so that they can start managing those risk factors. Another risk factor for AKN is close shaving, and we'll talk a lot about that. And chronic friction, probably from stiff collars or helmets, depending on the patient's occupation. That may not be an easily modifiable risk factor, unfortunately. So recently, actually last year, a nice case control study was done looking at the risk factors for AKN. And here you see obesity, so again, that metabolic syndrome risk. But this idea of very close cropping of the hair, very close haircuts, especially those that cause trauma, really put patients at risk for AKN. I think we knew this, and I think patients knew this, but to see it in the literature, I think this was the first time it was so well demonstrated. I like to show this picture for two reasons. One is, we don't have a grading scale for the severity of AKN, but this is a nice picture of the progression of the disease in some patients, where you start with, separate papules and not very noticeable alopecia, to these papules coalescing into a plaque with very noticeable scarring alopecia, to even more and more involvement. But I also show this photo to remind you that, again, AKN does not just occur in people of African descent. There's actually a quite nice body of literature on AKN from East Asia. So here's some more photos of AKN, and just kind of just showing this mild, moderate, and severe manifestations of the disease. You can see here, we can catch patients in this mild category and start doing some prevention strategies. You could really prevent some serious sequelae and disfigurement. Just some examples of, I really wanted to show you this plate-like scarring here that can occur in some patients with AKN. And you can see on the border of this plate-like scar, there are these tufts of hair, and they are really symptomatic. I feel like these patients really have the biggest quality of life impact. It's itchy, it's burning, it's constantly uncomfortable, where those hairs are sort of trapped in the skin and causing chronic irritation on the border. And we'll talk about treatment in a little bit, but in patients who look like this, you really want to focus that treatment on those tufts of hair that are just perpetuating the inflammation. So management, let's get into that part. So of course, you tell patients to try to avoid stiff collars and helmets if possible, but if they're a professional football player or they're going into the office with a stiff white collar every day, that may not be avoidable. But avoiding close shaving can be avoidable. But I think it takes a really in-depth discussion with patients, because if you just say you shouldn't shave or you should stop doing what you're doing, just similar to what Dr. Barbosa was talking about, it doesn't really give the patient direction. It doesn't give them that many options. So the point of these types of lectures is to kind of increase that cultural competency. And so we're really going to get into the weeds here with Black men's hairstyling. So basically, I recommend that patients do not use razors at all on the back of the scalp, if possible. So, the first question is, how do you groom your hair? And who grooms your hair? You'll find that many men groom their hair with a barber, probably somebody they've known all of their lives, someone who cuts their friends' hairs and their family members' hair, so they have a relationship with that person. So it's always good to partner with the patient's barber or hairstylist, because if they have to weigh your advice over that of their barber, they will choose their barber because that's who they trust the most. So I definitely have conversations with barbers and stylists all the time to make sure that we are a team, we're on the same page. So no razors, but if they are cutting the hair, I recommend that they use a clipper. This is an example of what a hair clipper looks like. The clippers come with guards. So these are the multicolored guards here, and they are numbered size 1 through 8 usually. And the smaller the guard size, the closer the shave. And you can also remove the guard altogether and get really close if you just use the metal part of the clipper. So what I recommend for patients is that they increase the size of their guard. So if they're usually using a 1 or a 2, they can try going up to a 3 or a 4. So the hair is a little bit longer. You're not getting as close to the skin. And I recommend that they never take the guard off. And this is important because if a patient desires a fade hairstyle, so this is a fade hairstyle, an example of one on the left here. This is a very common hairstyle among African-American men. It's well groomed. They call this tightening up at the back here, where you taper the hair down in length from the top to the nape of the neck. And so usually to get this really nice tapered look, you remove the guard and get really close down here. So I recommend that they talk to their barber about still getting that tapered look, but starting higher so that you're never taking the guard off. We also talk about perhaps they can move from a fade haircut to an even Steven. So this is an example of an even Steven where you're not tapering the hair, you're basically leaving the majority of the hair at the same length. This person also tightened up back here, but this is one of the best examples I could find of an even Steven. You know, when you use this lingo, this language with patients, I think it really puts them at ease because they believe that, okay, this skin and hair expert really knows what they're talking about, even, you know, in my case. And so I think patients love when we get into the weeds like this with them. I did not learn this in residency. I credit my husband with this part of my education. So in terms of medical management, you know, I spent a lot of time on this kind of prevention strategy because I think that's actually the most important piece here. But in terms of our interventions that we can do, my favorite is a strong steroid in the morning. I tend to use clobetasol cream, and in the evenings, a retinoid, either tretinoin or adapalene. Often it's hard to get tretinoin covered for this indication by the patient's insurance, so we'll just use over-the-counter adapalene. And I also like to give them a benzoyl peroxide clindamycin after shaving. So if I can get benzoyl peroxide clindamycin combination gel covered, that would be the best case scenario. But if not, we use benzoyl peroxide wash followed by topical clindamycin. And that's usually what I do for people with mild AKN. For patients with, you know, more severe disease, in addition to that topical regimen, we'll also try some intralesional injections of steroids. So my preferred dose is 10 to 20 milligrams per cc, and I inject it into the deep dermis in the entire affected area. So I'm not going after those individual papules. I'm just treating sort of regionally. And then one of my favorite treatment options for AKN, especially on the severe side, is an Nd:YAG laser. So we use the long pulsed Nd:YAG, 1064 nanometer. Some patients require topical anesthesia, many don't. And these are the settings that we use, but it really depends, of course, on your machine and your patient's skin type. One tip I would recommend is if there's a lot of post-inflammatory hyperpigmentation, consider prescribing some hydroquinone 4% twice a day for about 4 weeks before you begin your laser treatment. It helps to lighten the skin, and that improves the efficacy, and it can actually decrease your epidermal side effects. And I would treat every 4 to 8 weeks, and they need usually at least 4 treatments, sometimes 6 or 8. Patients respond really well to this. And this is a patient from the literature where you can see they did a split scalp study. On the left side, the patient is treated with topical steroids only, and on the right side, they're being treated with topical steroids plus the Nd:YAG, and you can see they did much better on the right side. Another tip for the Nd:YAG and AKN, it really works best when the papules are small. So I tend to offer this more earlier in the course of treatment now than I did before. So basically the depth of the laser penetration is reduced by as much as the height of the AKN lesion. So lesions that are less than 3 millimeters tend to respond better. I'll still treat the larger lesions. I still think it works reasonably well. I really love this paper. I referenced it here on the slide because it helps me to discuss with patients what their outcomes might look like if we decide to do laser therapy for their AKN. So basically, we are going to epilate that area, which changes the appearance of the posterior hairline. And so if someone has pretty mild disease and it's really just the lower occipital scalp is involved, you're moving the hairline up just by a couple of inches, and that can look quite natural. And patients are usually very happy with that. And I'll show you a picture in a little bit. But in people with more severe disease, as it starts to approach the occipital notch, you're really moving that hairline up towards the occipital notch, sometimes above the ear. And that can be a little bit more noticeable, but still, especially in patients who are already accustomed to a fade type of hairstyle, this looks great and they're pretty happy. Now, in people who have disease that's extended above the occipital notch, by the time you're finished epilating, you've basically given them a crew cut. And so I think it's important to discuss this ahead of time to make sure that the patient's okay with that. And most of them are, because in the end, the discomfort from the itching and the burning, et cetera, is gone. And the appearance tends to be better. So here's some photos from the paper referenced here. And you can see that this patient's hairline was moved up by about 2 or 3 inches. And that looks great. It looks pretty natural. I don't think anyone would necessarily notice that. And here's a patient on the more severe side who ended up with this crew cut. But again, look at the difference in how much inflammation and likely how many symptoms he had before treatment versus afterwards. In terms of surgical options for AKN, I've seen a lot of patients who haven't done well after surgery for AKN. But there are patients for whom I think this is a good option if they can find someone who is an expert. And I really hope that over the next few years, we can grow a few more experts, a few more surgeons who are interested in offering this option to patients. Dr. Hugh Gloucester, who was at the University of Cincinnati for many years, he's an African-American Mohs surgeon. He actually published several years ago his surgical approach to AKN. And it's a really beautifully written paper. So I think anyone who's interested, who's surgically minded, can follow this to the letter and really help patients out. But basically, he does his usual surgical prep, and he uses a number 10 scalpel. And he mentioned that he had to change his scalpel multiple times during the surgery because the skin is so fibrotic. It dulls the blades very quickly, and it was really important to have a nice sharp blade. He did a layered closure with 3-O-Vicryl and 3-O-Proline, did a very simple dressing with petrolatum, non-adherent dressing and gauze, and importantly, he used a soft surgical collar to decrease neck movement for 2 to 4 weeks after surgery so that his patients can really heal with a nice linear scar. And so many of his patients had really great results. What I thought was really interesting and cool about his approach is he did this 2-stage excision for people with more severe disease. So he would basically do the horizontal ellipse that we just talked about for the first stage on the inferior aspect down here of the patient's AKN. 3 to 6 months later, after it's completely healed, he would then go back and remove the superior half. But importantly, you see this nice linear scar here. He would design the closure so that the scar from the first excision represented the inferior border of the horizontal ellipse for the second excision. And you can see how beautifully this patient healed, and I'm sure how happy he is. And of course, you would have to still do some medical management and your prevention strategies to keep these results. And of course, I think the risk factors are the same for patients with AKN and PFB. So anyone who comes in to see us for AKN, we examine them for PFB, or at least start having that conversation, and vice versa. So let's jump into talking about pseudofolliculitis barbae, or PFB. So PFB is basically characterized by dermal inflammation from a naked hair shaft in the dermis. There's nothing more inflammatory than a naked hair shaft in the dermis. And that hair shaft can enter the dermis in one of 2 ways. It can grow out of the skin and curl back and pierce the skin through the epidermis, or it can actually make a 90-degree turn within the hair follicle itself, pierce the hair follicle epithelium, and enter the dermis that way. So the latter is called transfollicular PFB, and the former is intrafollicular PFB. Intrafollicular PFB is more common. And here's a nice close-up of intrafollicular PFB. You can see that hair really just diving back into the skin. It's incredibly inflammatory, very itchy, very uncomfortable. And so in terms of management, similar to and the prevention is key. Prevention and patient education is key. So We tell patients to avoid close shaving if possible. It's not always possible depending on their occupation, and we'll talk about that in a little bit. But thankfully, beards are in. So for some of my patients, especially with the pandemic, they were just like, okay, I'll grow a beard, and they grow their beard and they use products and balms and really get into it, and they can look really, really nice. But if the individual must shave, we talk about using clippers if they can instead of the razors, and we'll talk about that. And if they are using clippers, they should try to use guard number 1 if they need a close shave, meaning do not remove the guard. To use just the straight metal on the skin. For patients who cannot avoid shaving and who, for some of them, the number 1 guard would actually leave too much hair on their face if they're in the military, if they're in law enforcement, etc. And they might actually need your help in order to be able to avoid shaving. So I have this templated letter here for patients if they require it. I say I'm treating patient X for razor bumps. Sometimes this is necessary for AKN as well. It's caused by, the hairs growing back into the skin, and it's worsened by shaving. Please allow them to wear a closely cropped, well-groomed beard, and usually patients are able to do that. However, more and more information is coming out that even in the military, even if you are allowed to grow a little bit of hair on your face, it's not great for your career. So basically they're saying, hey, you can stay in the military, but for example, in the Air Force, you will never be an honor guard, you will never be in the band, you'll never be a recruiter. And the important thing about this is these are positions that are really important if you want to get promoted in the Air Force. And so this story came out that, over 60%, of course, of the people affected by this were Black or Latino, and their careers basically stagnated because they couldn't shave their face. And so I thought I was helping patients, and in fact, that may not be true. I have a colleague who is a military dermatologist who is actively working on advocacy for this. She's actually also working on some advocacy projects for some of the limitations that Black women in the military have in terms of how they can style their hair. So I hope that we'll make some progress on this soon. But I now have a different conversation with patients about this. So if they're in the military or law enforcement or they need a shaving profile, we start talking about other options much faster, like laser hair removal. Or, if you're going to be career military, well, maybe you don't need any hair on your face and we can just epilate. We talk more about depilatory creams because, I want them to be an admiral someday if that's what they want to do, and I don't want their beard to stand in their way. So in terms of shaving suggestions, I really get in the weeds with patients with this. So I recommend that before shaving, they wet the beard with warm water and use some kind of moisturizing foam or moisturizing cream. I was actually really surprised when I started asking patients how many of them just dry shave their face. They're running out the door, they're in a hurry. So we say no dry shaving. And sometimes I'll actually use benzoyl peroxide wash as their shaving cream. So, you're treating as well as having a nice barrier to the skin. I actually recommend that patients shave more often. I think the shorter hairs won't have a chance to grow out and curl back if you're shaving them every couple of days. And that's what I mean by more often. It doesn't necessarily mean daily, but every 2 or even 3 days. And everything I say here, this is all my opinion and what has worked for some of my patients and members of my family. I think everybody approaches this very differently. So I'd be curious to hear how other people counsel patients about this. And then during shaving, as I mentioned before, use clippers if you can instead of razors. But I have patients who tell me that clippers make their PFB worse. And then I have patients who swear by the 3-blade razors, and some swear by the 5-blade razors. So I don't necessarily differentiate between those two, but I think both the 3 and 5-blade razors are better than the single blade razors. I tell patients to shave with the grain, meaning in the same direction of the hair growth. although there was a recent study done by Dr. McMichael's group that showed, at least in their study, when patients shaved against the grain, they seem to do better. So again, I just ask patients what works for them. I think they should make only one pass with the razor. If they have to do multiple passes, that razor is dull, they should change it. And then I also recommend that they don't pull the skin while they're shaving, because if you pull the skin, the hair follicle the hair itself, extrudes a little bit. You cut it at a sharp point and then it retracts back under the surface of the skin. And I think it's just easier for it to penetrate this, that transfollicular PFB that way. So don't pull the skin while shaving. And I'll give them a little handout sometimes with, a little cartoon on what I mean by with the grain and against the grain, if that's new for them. And remember, PFB can occur in women as well. So I'll usually get way in the weeds with the women because some of the men already have this, under control. And then after shaving, I recommend that they wash their face with benzoyl peroxide or a salicylic acid over-the-counter face wash. They can apply either my topical prescription, which I'll talk about in a little bit, or they can apply their over-the-counter razor bump products. Many of my patients are very wed to their razor bump product of choice. It's the same bump stopper or whatever that their dad has been using, their friends are using, and so I don't take that away from them, especially if they think it's working. And I'll show you some of those in a little bit. And I do tell patients that they can remove the visible ingrown hairs if they'd like to. And I think that's controversial because some people feel very strongly about not removing the hairs. But what I've seen is when the hairs are removed gently from the skin, that inflammation, that irritation stops almost immediately. They feel better almost immediately. And so I just tell them, get a pair of clean tweezers and just slide it under the hair and just gently pull that hair out of the skin. They don't have to pluck it, but many of my patients do because they feel like personally offended by this hair, so they'll pluck it out. They can also use a clean toothbrush that's set aside just for this purpose and just use, wet it and just use gentle circular strokes. And that also dislodges the hair very gently from the epidermis. So my favorite management for PFB, in the morning, I'd like to give them a combination benzoyl peroxide clindamycin gel. If it's not covered by insurance, we'll even try the benzoyl peroxide erythromycin gel if we have to. Or again, you could do the benzoyl peroxide wash and the topical clindamycin. And then at night, I really like for everyone to have a retinoid. I think the retinoid helps with the PFB itself, but I also think it helps with the post-inflammatory hyperpigmentation that our patients are also very concerned about. So I use either tretinoin or adapalene, but I really like those combination products if I can get them covered. So adapalene plus benzoyl peroxide, that's like my best case scenario. They use that at bedtime. Or there's a tretinoin plus clindamycin combination product that's also excellent. And I just wanted to show this to you. I checked this on goodrx.com using the zip code near the University of Oklahoma, hoping that it would be helpful for many of you. So this is not going to be covered for this diagnosis by most insurance companies, but a 20-gram tube, not the 45-gram, the 20-gram tube of tretinoin is about $20-something in my area, and it seems like it is in your area as well. So, I think we often don't prescribe retinoids when we want to because we're worried about the prior auths and all of that paperwork. But if you just direct patients to GoodRx, this is pretty affordable. A 20-gram tube is going to last them at least a couple of months. And in your area, that lovely adapalene benzoyl peroxide combination gel, that's $37. That's not bad. And it's a 45-gram pump. That's going to last 3 months, 4 months, and it works really, really well. So please give it a try. Some other treatment options for PFB, if it's really inflamed, the patient's really itchy, I would use a topical steroid for a couple of weeks as needed, something nice and mild, like a hydrocortisone 2.5%. But some patients do need a medium strength, like a triamcinolone, if they're really inflamed, very uncomfortable. If the patient has secondary infection or I see lots of pustules, I'll do oral doxycycline or minocycline for a couple of weeks. I love laser. hair removal with the NDI for the PFB as well. In some patients, the goal is epilation, but in some patients, if we take the fluences down a little bit, they don't epilate, it just treats the inflammation. It's very interesting. So they don't lose their ability to grow a beard, but their PFB gets better after 2 or 3 treatments with the laser. So not a lot of literature out there about that, just my anecdotal experience. I think salicylic acid chemical peels can work really well for the same reason they work for acne. And of course, if the patient can avoid shaving altogether, they have no problem. If they can grow a beard or use a depilatory cream, excellent. That's what we'd like to do. And then just to show you some of the over-the-counter treatment options for PFB, I have no relationship with any of these companies, but these are 3 very common, very popular options. And they have good ingredients. Some of them have retinols, some have aspirin, chlorhexidine, and they seem to work. This one on the right here is the one that my husband uses. He's married to a dermatologist. I'm happy to help him. I'm happy to prescribe stuff, but he doesn't want my prescription. He wants to use Paw Patrol. So it seems to work. I just don't get in his way. So just another tip, remember that like acne, like many of our cutaneous disorders and skin of color, the PIH, the post-inflammatory hyperpigmentation, may be more bothersome to the patient than the actual primary disease. So once the acute inflammation is under control, we have a good regimen in place, we start working on that PIH right away. Thankfully, some of our treatment options, so the tretinoin, the adapalene, is already working on the PIH. So I definitely talk to patients about that. But you can add a hydroquinone 4%. You can add azelaic acid 15 to 20% to help with PIH. Or you can just use the compounded medications with hydroquinone, a topical steroid, and a topical retinoid. So 2 of those things you already would want to use for PFB. So if you can get that compound covered, that's actually a great option for the first month or 2 to really help the PFB and the PIH at the same time. And of course, sunscreen. I tell my patients to remember to wear sunscreen on not just the face, but also on the neck to help the PIH fade a little faster. One of the things I didn't mention is, of course, laser therapy is not covered for AKN and PFB. It's not covered for anything really. And so what we have done is we've decided to significantly discount the cost of laser therapy for medical applications. So PFB, AKN, dissecting cellulitis of the scalp, hidradenitis suppurativa, those patients do not pay the typical rates that our cosmetic patients pay. I just wanted to give people more access to this really great option. So in conclusion, some of these follicular disorders in men of color, AKN, PFB, we didn't talk about dissecting cellulitis of the scalp, but I consider that one of those follicular disorders that occurs in men of color. We really don't have a lot of research in these areas. And I think if we would invest in more research here, it could actually inform our general understanding of hair follicle biology and perifollicular inflammation. It's so accessible and it's so common. I hope we can do more work on this. I think there's a significant and underappreciated impact on our patients' quality of life. And especially as we talked about the shaving profiles for the military and the fact that this is actually affecting people's careers. I think these diseases are common, they're impactful, and the prevention piece, the patient education piece, I think that's much more important than our medical management. And again, depending on the circumstances of their employment, the patient may need your help to obtain permission to avoid shaving. So thank you so much for having me. I think we have some time for questions.
Thank you, Dr. Okoye. That was wonderful. I'm sure that there are questions that are coming in from the chat. Dr. McLaughlin?
Hi, Dr. Okoye. Thank you so much for that wonderful talk. We have many questions that have been coming in. One questions that have come through is that one of the commenters stated that they see acne keloidalis nucleae frequently in Mexican and Central American men, but they have not ever seen it in women, and was curious if that was your experience as well.
So that's an important observation. I have seen it in women who sport a fade hairstyle. So that risk factor with the hairstyling is really important. And that's probably why we're not seeing it in women, because most women don't take clippers to the back of their scalp.
Excellent, thank you. Another question is, in terms of your perspective, is there a relationship between triple CA and AKN? And do you see them together in the same patient?
Yeah, yes, that's a great question. So CCCA occurs, of course, predominantly in women of African descent, but I think it's very underdiagnosed in men of African descent because we tend not to biopsy them. We call them androgenetic alopecia and we don't take a closer look. But it's true, I feel like in patients with AKN, if you look at the vertex scalp, many of them, especially those with more severe AKN, many of them will have evidence of scarring on the vertex scalp. I don't think anyone's written about this or studied it, but I think that there is a relationship. I mean, they're already showing us that they can mount this chronic inflammatory response and scarring response in relation to inflammation. So, of course, they would have the same profile on the vertex.
Excellent, thank you. This question may have already been answered, but for patients that are prone to keloids, is surgical management of AKN an option?
No. So if the patient has already shown you that they can make a keloid, they have a keloid on their arm from a vaccination or from an acne bump in their beard area, they're not a great candidate for this surgery. But I think what happens is we erroneously believe that AKN represents a keloid, which it doesn't. So I think some of the patients who would qualify for surgery are being misclassified as having keloids and therefore not good candidates. I hope that makes sense. Excellent,
thank you. And another question that's come through is there a role for superficial radiation therapy in the treatment of AKN?
I think more of superficial radiation therapy for keloids. So if the patient has true keloids within their AKN, then that would be an option. I think it's another good option for very severe dissecting cellulitis of the scalp. But when I think of AKN in its pure form, I don't think we need to do radiation therapy.
Excellent, thank you. Another question that came through was, would you mind providing the name of the colleague that was pursuing advocacy work for the patients with PFB in the military? And that work sounds like a natural extension of the Crown Act.
Yeah, so that is Dr. Helena Pacheca. I can put it in the chat. I'm proud to say she was one of my residents many years ago, and she's at Walter Reed.
Excellent. Another question that came through is, do you tend to stick with the low potency retinoid, or is there a benefit in increasing the retinoid potency for patients who seem to tolerate more of the lower potency? For instance, do you increase the strength of the tretinoin? Do you go up to 0.1%, or you just step up to go to Tazorac?
Yeah, definitely. I think the patient can tolerate it, and if they can get it covered and or afforded with good RX, then yes, we do the same thing that we would do for acne. But if we start at 0.025% and they're having good results, I don't think there's any need to escalate. But I will say I haven't seen people get irritated that often from Tazorac or even higher doses of tretinoin in that area. So you can.
Excellent, thank you. Another question is, how do you counsel patients with AKN to stop picking?
I mean, I guess we try to treat the inflammation because they're usually picking because it's really irritating. So I think treating the inflammation is key. And if picking is a big part of what I'm seeing, like I'm seeing a lot of the sequelae of picking, then I might actually be much more aggressive. So I'm more likely to give that patient 2 to 4 weeks of doxycycline, for example, to try to squash that inflammation as fast as I can. I may be more likely to do intralesional Kenalog, intralesional steroids early, again, just trying to get them a little bit more comfortable.
Perfect. Another question that came through is, many of the treatment medications for PFB can be drying to the skin. And what are some ways that, or some advice that you have in order to combat this?
So, I think we especially when we prescribe retinoids for the face for acne, we have a spiel about, starting every other night for a couple of weeks and then increasing to every night. following that with a moisturizer or even layering a moisturizer underneath your retinoid. So if someone's getting dry or irritated, I'll go through that same spiel with them. I don't think it's that different from using tretinoin on the face.
Excellent. Do you have any experience or any comments on using narrowband UVB therapy for patients with AKN? And also, as a follow-up to that, would you consider a prophylactic IL Kinlog during surgical management of AKN patients?
Yeah, so the first question, that's a really fun question for me, because the very first grant I ever got was from the Skin of Color Society to study that very question. We used targeted narrowband UVB, a little device, to treat patients with AKN. To be honest, we didn't see a lot of improvement. We saw a little bit of improvement, and we did a nice little poster and then a little paper, but clinically, I don't think it made a huge difference. So I don't use it for patients. And then the second question, so I guess the person is referring to after the large surgical excision of AKN, injecting steroids to try to decrease the risk of keloids. Again, if the patient hasn't shown you that they make keloids, the AKN itself is not a keloid, and having AKN isn't a risk factor for having keloids. So no, I wouldn't necessarily treat them post-excision like I would a keloid patient. I think it's really that immobilization piece with the neck collar. I think that was really important for a nice cosmetic outcome. And with all excisions, if we do pressure with like silicone dressings and so on, we're going to decrease the risk of hypertrophic scarring. But if the patient isn't at risk for keloids, then no need to do that.
Perfect, thank you. And last question are, what are your thoughts on the role of intralesional steroids for the management of PFB?
So I think if patients have one or two really stubborn inflammatory nodules, and I've definitely seen those patients before, or patients who develop a small keloid or hypertrophic scar in an area where they had an area of folliculitis, then I might use a low dose of steroids, like 5 milligrams per cc. I'm really trying to avoid atrophy and hypopigmentation because that's such a cosmetically sensitive area for our patients. So I think yes, in certain situations, but I think that field therapy is better. Otherwise, you're chasing the lesions around.
Excellent point. Thank you so much.
My pleasure.
Dr. Okoye, I have a couple of questions for you. How would you best be able to engage with our barbers? We have invited them on today, as well as other hairstylists and specialists, but to get to the masses, to be able to educate them on these issues and to not only take heed of the recommendations, but to get them to refer to a dermatologist sooner than later. What's the best way to engage them?
So what I did before going to Howard, I was at Hopkins for 10 years. And so I really just embedded myself in the community. So I started with my own hairstylist. So in that stylist's salon, there were barbers there as well. So, I gave my card to people. I would actually do little consults, like, oh, my client has this. Can I send you a picture? Sure. So I was very much at their disposal. And then we actually did a couple of community events where one year we actually had a little community symposium for hairstylists. And then the next year we did one for barbers. So it wasn't for medical professionals at all. It was for them. And so they came, they kind of communed with each other, met us, we did a little lecture. More importantly, I wanted to hear from them because I can't tell you how much of this stuff I've learned from stylists and barbers, not from our dermatology textbook. So I always wanted to make that clear to them that they are experts and it's a bi-directional flow of information. I found that those symposia where and we didn't invite them to campus. We did the event in the community. And importantly, we did it on a Monday. Many stylists and barbers do not work on Mondays. That's their, weekend. Sunday and Monday is their weekend. So when we try to have things at other times in the week, especially like a Friday, that's a really busy day for a stylist, and they simply couldn't come. So, just some tips and tricks.
Excellent. What about have you seen the little battery operated hair trimmers? They kind of look like a toothbrush,
Yeah.
but to trim, are those okay to utilize as well when trying to get a closer cut, but without not too too short?
Yeah, I think as long as they're adjustable. So if you can adjust it to, similar to having like the guard 1, 2, 3, 4, 5, if you can adjust the length of the cut, then patients can sort of fine tune at what length are they having less inflammation. So they can use any tool they wish, but if they get too close, they're gonna have it.
Great. Within our department, we've been able to get both the AKN and pseudofolliculitis barbae approved for laser treatment as an inflammatory diagnosis. Yet patients may most of the time have a high deductible that they have to meet. So many times our departmental cosmetic prices may be even cheaper for them. But what is your experience with regards to insurance approval?
I just have had no luck with this. I've tried everything, letters, pictures, papers from the literature, and sometimes the insurance will actually say yes, they'll cover it, and then they don't. So I've stopped because it would take so much time and make me so upset that I just started making it much cheaper for patients. And that was true in Maryland, and I'm finding it to be true in DC. But are there specific codes that you're using, specific ICD-10 codes or CPT codes that you're having better luck with?
We use the actual code of pseudofolliculitis barbae and the CPT code of 96920.
Yeah.
And for most, that's not been an issue. Now with our Medicaid patients, that might be more of a challenge. But
maybe that's my issue, because I think 70-something% of our patients are Medicaid. So.
I got it. Well, we have just a few more minutes till 10. Did you want to discuss any quick things about dissecting cellulitis and how that looks just a little bit, and what people, especially our barbers and those that might be looking at the scalp in that way, what they need to look for?
Sure. So dissecting cellulitis of the scalp is basically another chronic inflammatory type of folliculitis, again, more common in Black men, where patients develop these big boggy nodules all over the scalp. It tends to start on the vertex or the top of the scalp, and then it can extend throughout the scalp. And the risk factors are also very similar. Metabolic syndrome. So I would screen these patients, screen their lipids, their hemoglobin A1C, and close shaving also aggravates. I don't think it causes dissecting cellulitis. I think it just aggravates it. And it's also just difficult to shave without traumatizing the scalp because the contours are so different. It's just very bumpy and lumpy. But in terms of management for dissecting cellulitis, so compared to AKN and PFB, where I feel like the prevention strategies, the patient education, the barber and stylist partnership are more important. With dissecting cellulitis, I actually feel the onus is on us, the providers, to treat that one. Most people first line will use oral antibiotics for the treatment of dissecting cellulitis of the scalp. However, I would encourage you to shift that paradigm and actually think about using isotretinoin as your first line treatment. There was a nice systematic review done that suggests that we should do that first. I've seen it does, not every patient responds, but when they do respond, it's beautiful and it's durable. And so I always want to give people a chance to clear with isotretinoin. And I use usual acne dosing, but I treat them not really weight-based. I treat them until they're clear, and then I go 3 or 4 months past when they're better. and then we stop and see if it recurs. It often does. If it recurs, I put them back on low dose isotretinoin, like 20 milligrams a day. And sometimes for some people, that's enough to keep it away. So I love isotretinoin for dissecting of the scalp. So the next patient you see, when you go to reach for doxycycline in your head, think of isotretinoin first. I don't really like intralesional steroid injections for dissecting cellulitis. I just don't think it works that well, and patients have told me it's just incredibly painful. And we do lots of ILK, so we know that people tolerate it quite well, but there's something about dissecting cellulitis of the scalp where I just feel like it's torturing them. So I don't use that very often, but I do use laser. I use NDI for DCS as well. It's much more time consuming because you're doing the entire scalp. It results in patchy epilation, so not every patient really wants that. And I implore you to use plastic wrap on the patient's scalp because you can have splatter of the lesional contents as you're treating with NDI. So one of my residents is still traumatized by that. So we never forget.
Do you tend to take a culture?
So I used to do that very often, and then I found that everybody was growing like either normal flora, mixed flora, or staph species. And just like hidradenitis suppurativa, we know that DCS is not infection. So I tend not to culture it. However, I will often send a fungal culture because there are many reports of DCS, of tinea capitis masquerading as DCS. And I've definitely been fooled before. And you want to catch tinea because a lot of the things we'll be using for DCS will make tinea worse.
Very good.
And then one more thing to think about with DCS, anabolic steroid use is a risk factor for development of that. So you definitely want to include that in your history taking. If somebody just sort of pops up with DCS out of nowhere, especially if they don't generally fit the demographic of people you'd expect to have DCS.
Very good.
That's
Thank you so much. This was just so informative. We thank you from all the way from DC.